His doctor said yes, but Medicare Advantage said no. Let me tell you about Frank. Frank was 74 years old when a blood clot cut off blood to his brain. It happened on a Sunday morning in Pittsburgh while he was trying to pour coffee. The mug slipped from his hand, and his wife, Ellen, asked if he was all right. Frank tried to answer, but his words came out tangled, so Ellen called 911. By that evening, Frank was in a hospital bed, struggling to speak. His right leg could move, but it could not reliably support his weight. His right arm rested against the blanket, as if it no longer belonged to him. The doctors told Ellen the stroke was serious, but Frank still had potential. He was alert, he could follow instructions, and he had been walking the day before. With intensive rehabilitation, they believed he had a real chance of walking again. 3 days later, the physician recommended transferring Frank to an inpatient facility. This was not a nursing home, but a hospital-level program for intensive therapy. It included physical, occupational, and speech therapy with constant medical supervision. The rehabilitation facility accepted him, and the hospital was ready to transfer him. His doctor said yes, but then Frank's Medicare Advantage plan said no. The denial appeared as a short message in the hospital's computer system. The plan claimed he did not meet criteria for inpatient rehabilitation. No one from the insurance company had examined Frank in person. No one from the company had watched him try to stand. No one had seen Ellen hold his belt, fearing he would fall. Even so, the answer was just no. Ellen assumed the denial meant the doctors had been wrong about his condition. She thought Medicare had reviewed Frank and decided he did not need care. That was not what the denial meant. It simply meant the plan had made a coverage decision. Those are not the same thing. Frank's daughter, Sarah, asked the case manager what the family could do. The case manager explained they could appeal for an expedited reconsideration. So they appealed, and then they waited. On the first day, Frank remained in the hospital while paperwork moved around. On the second day, a therapist helped him stand for 20 minutes. On the third day, the plan requested yet another therapy note. On the fourth day, the hospital told Ellen that Frank was medically stable. He could not remain in an acute care bed while the family disputed his discharge. A skilled nursing facility had an opening, but it lacked the intensity recommended. Ellen felt she was being asked to choose between two poor, miserable options. Either accept the bed or risk bringing home a man who could not walk. She accepted the skilled nursing bed, resigning herself to the situation. On the seventh day, after Frank had been moved, the insurance plan reversed its denial. Inpatient rehabilitation could now be covered, but the bed was already gone. Another patient had taken the spot, so Frank remained in the facility. He received therapy and eventually learned to transfer from a wheelchair with help. He could take several steps with a walker and a person beside him, but he never returned to the independent walking he had before the stroke. No honest physician can tell Ellen exactly what would have happened otherwise. Stroke recovery cannot be repeated under different conditions for a comparison. The stroke damaged his ability to walk, and the insurance did not cause the stroke. But the denial determined how quickly and how intensively Frank received therapy. That distinction matters, even if it is hard to quantify. Frank's story is a composite based on patterns in Medicare Advantage oversight reports. The names are fictional, but the broken system is definitely not. In June 2026, the federal government released findings everyone should understand. Investigators reviewed 19 organizations regarding requests for skilled nursing facilities. Collectively, the plans denied 12% of those requests. Only 18% of the denials were actually appealed. But when people did appeal, the organizations overturned 95% of them. That figure does not mean every denial was inherently malicious. It does not mean every patient should have been approved. It means among the minority who challenged the denial, nearly everyone was reversed. The most important number might not be 95%. It is likely the 18% because 82% were never appealed. Some patients accepted other care, some paid privately, or some went home. Others simply never realized the first denial was only the beginning of the process. A denial can sound final when you are 78 years old, medicated, frightened, and lying in a hospital bed. It can sound final when your spouse has not slept in 3 days. It can sound final when the person reading the letter has never heard terms, such as organization determination, expedited reconsideration, or independent review entity. But a Medicare Advantage denial is not necessarily the final decision. Sometimes it is the first point at which a patient needs someone who understands the appeal process. That is the system we need to examine. Medicare Advantage is an alternative to original Medicare, and these plans are offered by private insurance companies approved by Medicare. When you join one, you remain enrolled in Medicare, and the plan must cover the basic benefits provided under Medicare Part A and Part B. However, the plan may use a provider network, it may require referrals, and it may also require prior authorization before agreeing to cover certain services. Prior authorization means that the health plan reviews a proposed service before the patient receives it and decides whether the plan's coverage requirements have been met. In principle, prior authorization is intended to prevent care that is unnecessary, duplicative, or inappropriate. That goal is not unreasonable, as every healthcare system needs a way to control waste and ensure that treatment is appropriate. The problem begins when a cost control process becomes a barrier between a physician's recommendation and a patient's access to care. Medicare Advantage organizations generally receive predetermined payments to manage the care of enrolled members. Federal investigators have repeatedly identified a central concern with this structure. Because plans are responsible for controlling costs, they may have a financial incentive to limit services. That does not prove that every denial is financially motivated, but it explains why independent oversight is necessary. A private company is deciding whether to pay for care while also being responsible for managing the cost of that care. The physician sees a patient who needs rehabilitation. The plan sees a request that must meet its coverage requirements. Those two perspectives can conflict at a critical moment in a family's life. The federal government has already found evidence that some denials should not have occurred. In an earlier review, the Department of Health and Human Services Office of Inspector General examined denied prior authorization requests from large Medicare Advantage organizations. It found that 13% of those denied requests actually met Medicare coverage rules. Those services likely would have been approved under original Medicare. The examples included advanced imaging and post-acute care, such as inpatient rehabilitation. Investigators identified two common reasons for the denials. Some plans used clinical criteria that went beyond the requirements in Medicare rules. Some plans said records lacked documentation, even though reviewers later found them sufficient. Care could be necessary and documented, yet still be denied during the initial review. Newer findings on inpatient rehabilitation and long-term acute care raised similar concerns. The three largest Medicare Advantage organizations denied requests at some of the highest rates. When rehabilitation denials were appealed, the plans collectively overturned 43% of them. The overturn rate ranged from 14% to 86% across different organizations. That variation is more than a minor difference in administrative practice. It means approval depends partly on which insurance card is in the patient's wallet. Two patients with similar medical needs may face very different barriers during their care. A low premium, a dental allowance, and a television advertisement do not tell the story. The real value of insurance becomes clear when a patient needs expensive care. Few people choose a Medicare plan while imagining a stroke in their future. They decide at a kitchen table, comparing premiums, copayments, and supplemental benefits. Once the ambulance arrives, prior authorization rules matter more than a gym membership. New protections finally took effect in the year 2026. Affected payers must issue decisions within 72 hours for expedited requests. They have 7 calendar days for a standard request. That is progress, I suppose. But 72 hours is still 3 full days of waiting. A deadline for issuing a decision is not a deadline for beginning treatment. A plan can deny a request within the required period, just to save money. The family must then recognize the denial, contact the physician, and request reconsideration. The process may be operating within the rules, while the patient continues to wait. Medicare Advantage plans are required to follow national and local coverage rules. Prior authorization should confirm medical necessity, not create an entirely different benefit package. Approvals for a course of treatment must remain valid for as long as the care is medically reasonable and necessary. This is based on applicable criteria, the patient's medical history, and the treating provider's recommendation. Plans must also maintain utilization management committees to review their policies. These requirements matter, but rules do not apply themselves at the bedside. Families need to know what to ask for. Here is a 5-part action plan for situations in which a Medicare Advantage plan denies medically necessary care. Number 1. Ask whether the request was submitted as expedited. An expedited request is appropriate when waiting could seriously jeopardize the patient's life, health, or ability to regain maximum function. Do not simply ask an insurance representative to move faster. Ask the treating physician to document why a delay creates medical risk and to request an expedited review. When a physician requests an expedited reconsideration, the plan is required to expedite it. Use specific language, maximum function, medical risk, and expedited reconsideration. The wording matters because the system responds to defined categories. Number 2. Obtain the written denial. You need the official notice explaining what was denied, why it was denied, and how to appeal. A phone representative saying it was not approved is not enough. Ask for the notice of denial of medical coverage and which exact medical criterion the patient failed to meet. Do not accept a vague phrase, such as not medically necessary, without asking who made the decision. Number 3. Build the appeal around medical facts. An emotional appeal from a family may be understandable, but a medical appeal requires medical evidence. The physician should explain the diagnosis, current functional limitations, and the required intensity of therapy. Also include the risks of a less intensive setting and the specific Medicare coverage criteria the patient meets. Ask the physical therapist, occupational therapist, and hospital case manager to contribute documentation. A denial based on missing information may be reversed by presenting the medical need more clearly. Number 4. Do not miss the appeal deadline. A Medicare Advantage reconsideration generally must be filed within 65 calendar days from the denial notice. But during a rehabilitation crisis, 65 days is not a useful target. File immediately. For an expedited pre-service reconsideration, the plan must decide no later than 72 hours after receiving the request. If the plan upholds the denial, the case is sent automatically to an independent review entity. The appeal process has multiple levels because the initial decision is not assumed to be infallible. Use those levels. And number 5, seek outside help. Ask for the hospital case manager or social worker and contact your state health insurance assistance program for free counseling. Call 1-800-MEDICARE if you need help understanding appeal rights or filing a complaint. If a provider says that covered services are ending, read every notice immediately. Some fast appeal deadlines are measured in hours, not weeks. Do not set the notice aside for later because later may be too late. There is one more question families should ask before a medical crisis occurs. What does your Medicare Advantage plan require for post-acute care? During open enrollment, people compare monthly premiums, drug formularies, and dental benefits. They rarely ask how often the plan requires prior authorization for rehabilitation, imaging, or surgery. They rarely ask which rehabilitation hospitals are in network. They rarely ask how the plan's denial rate compares with other plans. Part of the reason is that consumers have not always had access to clear, comparable information. Beginning in 2026, affected payers must publicly report certain prior authorization metrics. Greater transparency matters because a Medicare plan should not be judged only by what it offers healthy members. It should also be judged by how it treats seriously ill members seeking expensive care. Medicare Advantage is not automatically bad. Millions of Americans value its predictable limits, coordinated networks, and supplemental benefits. Some plans manage care well, and some patients receive prompt approvals and excellent treatment. Original Medicare has its own gaps, costs, and complications. This is not a simple story in which one system is good and the other is corrupt. It is a story about an imbalance of knowledge and power. When a patient is weak, confused, or unable to speak, the plan understands the rules better than the family does. The plan has employees, contractors, software, criteria, lawyers, and an appeals department. The family has a denial notice and a telephone, and those are not equal resources. Information is one way to narrow the gap. Frank's family learned the system only after the denial. They learned what expedited meant after several days had passed. They learned that an approval can arrive too late to restore the original opportunity. They learned that winning an appeal does not return the time spent waiting. Ellen still keeps the approval letter in a drawer, not because it helped Frank, because it shows that the plan eventually agreed with the doctors. The letter records the approval and the date records when it came. That is the part she cannot forget, because the system did not say no forever. It said no long enough for the available bed to disappear. Remember this: when a physician recommends rehabilitation and a Medicare Advantage plan denies it, ask for the reason in writing. Ask for an expedited appeal, and ask the physician to document the medical risk of delay. Ask which Medicare rule the patient supposedly failed to meet, and continue asking questions until you understand whether the answer is truly no or only the first decision in a longer process. In American healthcare, the first answer is sometimes a medical decision. Sometimes it is an administrative error, and sometimes it is the beginning of an appeal that a patient or family did not know they had the right to pursue. This video is for educational purposes only, as Medicare rules, plan terms, medical conditions, and appeal procedures vary. Patients and families should consult their treating clinicians, their Medicare Advantage plan, Medicare, and qualified benefits counselors about their specific circumstances.